Psychiatry and the patients we treat struggle with treatment-resistant depression. That is, depression that doesn't respond to our usual antidepressant medications. My field is always looking for the next new antidepressant or alternative treatments like ketamine or psychedelics, electrical treatments like shock treatment or TMS. But what if the term treatment-resistant depression is misleading and has sent us down the wrong path? That's what we'll talk about today. I'm Dr. Stephen Reidbord, a psychiatrist in San Francisco with a mostly psychotherapy practice. I published psychotherapy research early in my career, and for decades I've taught psychiatrists in training about psychotherapy. And this is More Than Meds, where I talk about psychotherapy and psychologically informed psychiatry. How is treatment-resistant depression defined? There's no official definition, but according to reputable sources like WebMD, Johns Hopkins University, the Tavistock Clinic in London, the Cleveland Clinic, Harvard Medical School, treatment-resistant depression is when a depression has not responded to two or more first-line antidepressants that have been given at a sufficient dosage and duration, generally 6 to 8 weeks each. There's then usually a discussion well known to psychiatrists like me about what to do about it if a depression hasn't responded to two or more first-line antidepressants. And the suggestions include increasing the dose of the antidepressant or substituting a different antidepressant, or sometimes using two antidepressants at once, or augmenting, that's the term that's used, augmenting the antidepressant by adding another medicine which is not itself an antidepressant but helps antidepressants to work, like thyroid hormone supplementation or lithium. And then there's other alternatives like ketamine or more traditional psychedelics like psilocybin. There's electrical interventions like transcranial magnetic stimulation, called TMS, or shock treatment, officially called electroconvulsive therapy, or ECT. And then even less well-known treatments like vagal nerve stimulation, deep brain stimulation, and other really invasive biological types of treatments. Now, I'm not here to criticize those kinds of treatments. They clearly do help some people, many people, with severe clinical depression. But this kind of discussion, as I say, very well known to psychiatrists like myself, goes down a particular medical biological pathway. And that's a surprisingly narrow way of looking at something that's really so common. Because according to those reputable sources I just mentioned earlier, about 30% of people with clinical depression who've tried medications don't get better. 30% of people with significant depression have treatment-resistant depression, and 30% is a big number. If you do the math, that means that millions of people in the United States alone have significant depression that doesn't respond to medication. There's a bias, both by the public and by my field of psychiatry largely, and by medicine generally, to think of depression as a medical problem. There's still a lot of talk of chemical imbalances causing depression, even though mental health professionals have known for decades, for generations really now, that no such chemical imbalance has ever been found. I talk about that in this video right here. Now, that doesn't mean that medications are always a bad treatment. Medications can be helpful even for problems that didn't arise medically. For example, you could have anxiety or insomnia, poor sleep, because of an upcoming exam you are facing or some other life stress, and a medication could temporarily help you sleep better or relieve your anxiety, even though the original problem was not medical. Anyway, my point is not that medications don't help. They do help sometimes, often do. My point is that if 30% of depression doesn't respond to medications, maybe a lot of depression is not a medication problem. Because here's one fact that's rarely emphasized. Treatment-resistant depression is defined by its persistence, not by its severity. If you have a depression and it hasn't gotten better after 2 good trials of antidepressant medication, 2 or more, then that's defined as treatment-resistant depression, even if it isn't a very severe depression. It's been known for generations that many people suffer long-term, chronic, persistent, but usually mild depression. It can go on for years. We used to call this dysthymia, although it's my impression that more and more people are just identified as having depression, even when they fit that pattern. And for that reason, lots of people receive antidepressant medications for dysthymia, chronic low-level depression, even though it's been known for a long time that antidepressant medications are not a very good treatment for dysthymia. Now, this kind of flies in the face of common sense, I suppose. I imagine you might think that if an antidepressant works well on severe depression, it must work really well on mild depression. But actually, it doesn't work like that. It doesn't work as well on mild depression. You should also know that the great majority of antidepressants are not prescribed by mental health professionals, certainly not by psychiatrists. They're prescribed by primary care doctors or primary care nurse practitioners who naturally think more in terms of medication than they do psychotherapy. They mostly think in terms of medication treatments. So I'd suggest to you that treatment-resistant depression is a misleading term. It's really medication-resistant depression, because that's literally how it's defined and basically how it's recognized: depression that has resisted medication treatments. As you can tell, I'm about to suggest that psychotherapy has been systematically excluded from this discussion. But that's not entirely true. There have been a small number of studies and meta-analyses, that's a study of a group of studies, that have looked at whether psychotherapy helps in treatment-resistant depression. And the answer from those studies is that there's some weak evidence that psychotherapy can help. But the great majority of studies and the meta-analyses that look at those studies look at cognitive behavioral therapy. That's the psychotherapy they're talking about. And cognitive behavioral therapy, or CBT, is a very popular kind of psychotherapy nowadays, but it's very symptom-focused in much the same way that medications are. What I'd really like to suggest is that for patients with long-term, chronic, unrelenting depressions that are perhaps not so severe, that depth psychotherapy, the traditional kind of psychotherapy that aims towards insight and towards the healing power of the therapeutic relationship, is much more apt to be helpful. Now, why do I say that? Because this kind of psychotherapy particularly focuses on personality issues, personality compromises, really, that a person has developed over a lifetime. Issues of poor self-esteem, guilt and self-blame, repressed anger, and so forth can lead to a depressive personality style, a low-level persistent state that's really best thought of not as an emotional symptom to get rid of, like a headache or a fever, but more like a kind of an adaptation or compromise that the person's developed over the years to deal with internal struggles they face. I talk more about the psychodynamic approach, the depth psychotherapy approach to treating depression in this video here. I'll mention one study, though, by author and researcher Peter Fonagy and his colleagues from about 10 years ago, where they studied 129 patients with treatment-resistant depression. And they randomly assigned half of them to receive long-term psychoanalytic psychotherapy, while the other half received what they called treatment as usual, generally medication management, but also shorter forms of psychotherapy like CBT. And what they found was that there was no difference initially in the two groups, the psychotherapy group and the treatment as usual group. But when they looked 2 or more years out, long-term follow-up, they found that the psychotherapy group had fewer people who were still depressed, fewer people who continued to meet criteria for major depressive disorder, and also their self-rated subjective sense of well-being and general sense of life satisfaction was better in the psychotherapy group, statistically significant. When I was in training back in the 1980s, and cue the dinosaurs, we learned that clinical depression was largely episodic. It came in an episode. A person would be feeling well at their usual baseline. They'd come down with depression, a state clearly different from their usual way, and then an antidepressant could be given to help the person get back more quickly to their previous baseline. And then the antidepressant would be stopped unless they were in the minority and they had serious repeated depressions, in which case it would be continued. But the perception, I think, has changed over the years. Nowadays, we talk about depression like it's a medical problem. It's often compared to diabetes or high blood pressure, implication being that you've got this for the rest of your life and you have to keep taking medicine for it. That's not the way we learned about it. Now, there are certainly people, there have always been people, who have really severe cases of depression. And yes, they do need to stay on their medications or other medical treatment indefinitely, because if they stop it, they really become non-functional. But there's a much larger number who have what we learned 40 years ago was episodic depression. They were feeling well, they're depressed for a period of time, antidepressant helps, and then after 6 months or 12 months of antidepressant medication, they can stop it and feel well. Or they have a personality-based, long-term, chronic, smoldering, usually low-level depression. They function, but not very well, where medications really have never been very effective, don't really help with that kind of depression, but that depth psychotherapy can help with the depressive personality style that has led to that way of life. So what's the take-home message? Medications and other biological treatments for significant depression are good for what they're good for. Severe, usually episodic depression that leaves the person unable to work or go to school, often accompanied by a whole series of other biological signs and symptoms like poor sleep, poor appetite, inability to concentrate, lack of sex drive, suicidal thoughts, inability to enjoy or take pleasure in anything. Medications are good for that kind of problem, and I'm all for further research. We need more and better antidepressants or other kinds of biological interventions that will help such people. But in contrast, long-term chronic depression that may meet the criteria, the definition of treatment-resistant depression because it doesn't respond well to medications, may respond better to depth psychotherapy, a treatment that's specifically designed to tackle lifelong misery. Treatment-resistant depression is a misleading term. It's really medication-resistant depression. Logically, something isn't treatment-resistant unless all the reasonable treatments have been tried. So let me know your thoughts about treatment-resistant depression and anything else I've mentioned here. Please put it in the comments. I read every single one of them. Please like this video, but only if you really like it. Please subscribe if you have not already. And if you have a little more time, please check out this video, which is also about psychotherapy and psychologically informed psychiatry. Till next time.